We occasionally do have hyponatremia in our infants, but I can't say that it's more common in the babies who qualify and receive the exclusive human milk diet versus receiving cow's milk-based fortifiers. The common denominator is sometimes when we use pasteurized donor milk. Sometimes we do need to provide some sodium to the babies who are on primarily pasteurized donor milk for sustained period of time.
And see, for our unit, we just set up a guideline that if the sodium is less than 134, we know we automatically supplement sodium.
So currently at this point in time, we are monitoring the sodium, but we haven't gotten to the point where you are, where you're kind of taking it and automatically doing it to prevent that. So right now we're kind of in a reactionary phase, so I'm hoping that taking a little bit more information, we can look at that sodium and be able to move forward with that.
We occasionally do have hyperphosphatemia with our babies, and in those cases, what we have found is generally if we just watch it for a few days, it will resolve on its own.
I agree. With the hyperphosphatemia, I think it's a matter of it's a short-term issue. We've had very few babies that it's progressed past that 2 or 3 day time period. And I think it's also kind of looking at the total volume, I think, has helped us with kind of looking at those lab values for the phosphorus and for the sodium also.
And I would say in terms of hyperphosphatemia, it's really only come up less than a handful of times in our unit over the past almost 4 years now. The first thing that I did was to make sure that it was truly hyperphosphatemia, because sometimes depending on your electronic medical record and the lab values, you just have to make sure that it would truly be something to term as that. And as you said, that it resolves generally within 2 to 3 days. There have maybe been 2 times did not resolve that we just held the fortification for, really it was like 2 days and then resumed, and it wasn't a problem. There is a paper that basically says that the hyperphosphatemia has not been clinically significant and is transient. So that was reassuring that we were on the right track. I would say that hypoglycemia is not something we're concerned about in our unit in terms of seeing it in infants on the exclusive human milk diet. It hasn't been a pattern that we've noticed.
I have not noticed it in our unit either. I would think when we do normally see it for us, it tends to be some of our bigger babies that mom might have had issues with blood sugars during pregnancy. Sometimes with small babies, we will see hypoglycemia just in general, and in those cases, we just really try to make sure that we're managing our advancement of our feeding and transition off of our TPN appropriately to make sure that we're continuing to meet our needs as that process happens.
I agree. I think hypoglycemia is not only necessarily a nutritional issue, and so getting together with the team and really taking a look at how, especially in those small babies, how you're transitioning off of your TPN and looking at GIR and things of that nature. So using that fortification process is really important because it helps give us everything that we need to help maintain those glucose levels.
One intervention that could be considered if you do have an infant receiving the exclusive human milk diet and blood glucoses are low is changing the delivery of feeds so that perhaps it's given over a longer period of time, or occasionally, if severe, maybe even considering continuous feeds.
So for the hyperglycemia, sometimes what we'll do is also consider going to Q2-hour feeds with some of the smaller babies so that we're decreasing that amount of time that they're off before considering going to continuous feeds.
And again, if we go to continuous feeds for that purpose, we generally start looking at adding the cream so that we can replace those losses that might occur of fat over an extended time period. And cream can also help stabilize those blood sugars.